just based on where the artery is supplying blood to that portion of the brainstem, if you can identify the structures, you can identify signs and symptoms of medial medullary syndrome. Now we're going to look at lateral medullary syndrome. And lateral medullary syndrome is one of the more common ones. It's so common it has its own name. It's called Wallenberg syndrome. Okay? Wallenberg syndrome. Does anybody remember the name of the artery that's going to supply the lateral medulla to blood? It's going to be pica. So this is a disruption of pica. It's a disruption of pica. Okay. Same cross section. So all I'm going to do is go through and quickly label things again, starting. So let's go ahead and do the standard. So this is going to be dorsal. This is going to be ventral. That way you can tell left from right, which makes this the right side, and then this is going to be the left side. Most ventral in the medulla, we have these tracts here. Does anybody remember the name of this tract here? Yep, that's your CST. Corticospinal tract. Okay. There's going to be another, there's a cranial nerve here. This cranial nerve is easily identified as being in the medulla since it exits here in the pre-olivary sulcus. And this is going to be your hypoglossal nucleus. And then this is going to be your cranial nerve number 12. Okay. Moving again more medially. This long elongated structure that's present medially. This is your medial lemniscus. Dorsal to the medial lemniscus, sitting here on top. It's going to be your medial longitudinal fasciculus. Here in this bump known as the olive is going to be your inferior olivary nucleus. Responsible for receiving information, sensory information from the face is going to be, here's your spinal nucleus of trigeminal. Receiving sensory information from the body, specifically crude touch, pain, and temperature. Down here is going to be your STT. Usually hanging around with the STT is the tract we talked about today. going to be, this little black dot is your sympathetic tract. Okay, nothing more than what we just labeled. Here's the nucleus. It doesn't know who he belongs to. Cranial nerve 9 and 10, motor nucleus. It's going to be nucleus ambiguous. And then last but not least, you have your inferior cerebellar peduncle. Major afferent peduncle into the cerebellum.
Peduncle?
Peduncle. Inferior cerebellum peduncle. And like we talked about before, there's artery comes up here, the area of the pre-olivary sulcus, that's your vertebral artery, but coming off of your vertebral artery going out to the side is going to be your posterior inferior cerebellar artery. This applies the outside PICA, shown in green. And the territory for pica in the rostral medulla is going to be inside of these dots here. And realize it'll be happening bilaterally, but all of these structures are going to be affected with the disruption of pica. Okay, so if we start with STT, how will that patient present if STT is disrupted here? Crude touch, pain, temperature. You got it. Sympathetic tract is affected. How will that patient present? Horners, meiosis, ptosis, anhidrosis. Spinal nucleus of trigeminal is affected. How will that patient present? Sensory to the face, no matter what cranial nerve it's coming from, right? All sensory to the face is going to be affected. Nucleus ambiguous is affected. Motor nucleus for 9 and 10. How will that patient present? Difficulty swallowing and might have a hoarse, H-O-A-R-S-E, a hoarse voice. And the inferior cerebellar peduncle. There's a word begins with A that I'm looking for. How would that person... Ataxia. Ataxia is just a general word for lack of coordination. Okay, so that person will present with ataxia, swallowing problems, a hoarse voice, loss of facial sensation, problems with pain, crude touch and temperature sensation, Horner syndrome. Okay, the inferior olivary nucleus doesn't really have a presentation that's involved. And there's a little saying that goes with pica. So a disruption of pica, lateral medullary syndrome is a disruption of pica. And to help remember what all is involved in this artery disruption, there's a saying. It says, never pica, pick a, pica, never pick a small eyed, due to Horner syndrome, horse, H-O-A-R-S-E, or H-O-R-S-E, hoarse voice, that wobbles ataxia due to inferior cerebellar peduncle and can't swallow. Okay, never pick a small-eyed horse that wobbles and can't swallow. That's lateral medullary syndrome. So a person presents with ataxia, swallowing difficulties, a hoarse voice, small eye due to Horner syndrome. You got pica disruption, lateral medullary syndrome. Question?
So is the artery internal in the bottom? Is that vertebral or is that nervous?
So the vertebral artery is the vertebral artery is coming up. This is a cross section of the pica off of that artery. Yep. Comes off of that line. Every time. Any other questions? Lateral medullary syndrome is Wallenberg's. Okay. So with the ataxia and a hoarse voice and swallowing difficulties, you know it's cranial nerve 9 and 10 that's involved. So you're in the medulla. Okay. A lot of these syndromes are going to look similar, but you have to use the cranial nerve that's been disrupted as a key to whether you're in the medulla, the pons, and the midbrains on its own. Okay, questions about lateral medullary? Let's move on then to medial pontine syndrome. And we'll take some time to just go through here and label some stuff. All right. So, what color do I want to use? Looking in here, this is going to be the part of the ventricular system that is in the pons. Right here. Remember, which part of the ventricular system is in the pons?
Fourth.
Yep, this is going to be my fourth ventricle. Okay, so if you see this big old thing here in the middle of the pons, that's, or middle of the picture, that's the fourth ventricle, so you know you're in the pons. Let's label, this is going to be dorsal. This is going to be ventral. Okay. It's going to be the right side, and this is going to be the left side. So we're going to say, since we're only looking at one side here, we're going to say this is going to be a disruption of, let's say, the pontine arteries on that side. On the left. Okay, since basilar is right up the middle, we're just going to say the pontine arteries on the left side of the basilar. Okay, just to make it easy. Okay, so we're in the pons, thinking about cranial nerves, cranial nerve nuclei, and cranial nerves. There's going to be this cranial nerve nucleus that's most medial in the caudal pons. Does anybody remember the name of that one? Yes, that's going to be your abducens. Okay, so this is your abducens nucleus. Okay, and that makes this cranial nerve 6, which is exiting very medial here in the pons. Okay. Just a little bit lateral. The cranial nerve 6 nucleus is cranial nerve 7. This is going to be your facial nucleus. Facial nucleus. And the interesting thing about the facial nucleus, and you can look at the axon coming out of the nucleus, the axon coming out of the facial nucleus actually wraps around the abducens nucleus here and helps to form a border to this fourth ventricle. Okay, so the nucleus wraps around, nucleus sends out an axon, facial nucleus sends out an axon that wraps around this abducens nucleus before exiting the pons. Okay, and this is going to be cranial nerve 7. Okay, those are the main nuclei. Thinking about structures that are very ventral. going to be, this is going to be your most ventral. Everybody know what that one is? Mm-hmm. It's going to be your corticospinal tract. Corticospinal tract. And I think I use this color. This guy, he's still medial. He's presenting medially, and he's got an elongated structure. That's your medial lemniscus. Awesome. Okay, your medial lemniscus. This is something that in the medulla, these small black dots are closer to the medial lemniscus. They're still medial though, involved in conjugate eye movements. And this is your medial longitudinal fasciculus, MLF. On, we have this is tract that carries information about pain, temperature, and crude touch from the body all the way up to the, yep, this is going to be your STT. It's all coming back to haunt you. Usually hanging around with the STT is another small tract that we talked about today. It's going to be your, that's your sympathetic tract. Okay, I'm thinking about sensory information coming from the face. It's going to synapse here with this nucleus. That's going to be your spinal nucleus of trigeminal. There's a little nucleus that I've been representing as a kite for the entire semester, and its associated nucleus. This is going to be, the kite's going to be your vestibular nucleus, and that little circle that's associated with it is your cochlear nucleus. All the main players in the pond, and then we also have those peduncles to think about. I'm going to go ahead and draw my midline in just to make it clear. Okay, so up here it's going to be a large area bilaterally. That is the inferior cerebellar peduncle. Inferior cerebellar peduncle is there. You also have here, let's see, I guess I'll make it brown. This is your superior cerebellar peduncle. major efferent peduncle used by the cerebellum? Okay. And last but not least, we have this area here. This is going to be your large middle cerebellar peduncle. Okay. The pink one, that's your inferior cerebellar peduncle. The circle going up and down is your superior cerebellar peduncle. And in yellow, we have the middle cerebellar peduncle. Okay. Okay, so coming up the middle of the pons, we have that basilar artery here, and coming off the basilar, and we're going to be looking at a disruption of the pontine arteries coming off the left side of the basilar artery. So let's look at the pontine arteries on the left. Okay. And we know that those pontine arteries are going to supply the medial portion of the pons, as they're sitting there right in the middle of the pons, right? They're just in the middle, so pontine and basilar supply the medial portion of the pons. And if we look at the area supplied specifically by the medial portion of the pons, it's going to be, here's this, looking on the left side, okay, it's going to have a cutoff of here. So all of this region and all of the structures inside this area are going to be affected in medial pontine syndrome. Yes? Gabby? Huh? What? Okay. I don't know if I remember what I did in the last 3 sentences, but I'll just go back and see what I can do. So, this is the basilar artery coming up, and these are the branches off the basilar artery, the pontine arteries. And I'm choosing to represent that because I'm just looking at a left-sided problem right now. Okay, so that would just be the pontine arteries coming off the left of the basilar. Okay, so this is the basilar, these are the pontine arteries here. Okay, the area that the pontine arteries supply is going to be medial pons. And that makes sense because basilar comes right up the middle of the pons, right? So it's not going to be lateral, it's going to be medial. Everything in the middle is going to be hit. So the portion of the pons that is affected by disruption of the pontine arteries on the left is going to be shown here in the gray, and where I've tried to grade out. I think that's everything I said. Did you get that? Does that make more sense? Yeah, Caleb?
So spinal nucleus and SCT won't be affected?
Correct.
Okay, so that's all right.
Correct. Yes. Yes. It's going to look a whole lot like the medial medullary syndrome, only a different cranial nerve. Right? So everything's going to look pretty much the same, only that person's going to present with cranial nerve 6 problems, right? Their lateral rectus isn't working, so that eye is going to tend to deviate to the midline. Okay, whereas if you're in the medulla, same symptoms, but the tongue is going to be the one with the problem. So 12 versus 6. John?
Is the facial nucleus not included, but the abducens nucleus is?
That is correct. The facial nucleus is not included in medial pontine. Yes, pontine syndrome. Yes, Alex.
To confirm, this is all ipsilateral until we hit the trochlear nerve, and that's when we get to contralateral symptoms.
That would be, yes, that would be, we're not going to touch trochlear for patient presentation. So yes, all of your cranial nerves, if it's the nucleus or the nerve coming out, that's when it's going to be ipsilateral. However, the corticobulbar tracts, remember those in the midbrain? That's where it's contralateral.
Okay.
Then we're not there yet, but we'll get there. But right now, if you're disrupting the nucleus or the nerve, the axon's coming out, it's ipsilateral. Presentation for cranial nerves. Any other questions? So what I have affected here is going to be this medial longitudinal fasciculus up top, closest to the fourth ventricle. Patient's going to present with a disconjugate gaze. Okay, abducens nucleus is affected. That means lateral rectus isn't going to be working, so their eye is going to tend to deviate toward midline. They're not going to be able to pull it back out. Okay, coming on down, medial lemniscus is going to be affected. Okay, problems perceiving vibration, proprioception, and fine touch, as well as the corticospinal tract is going to be affected. Okay, that's going to present, patient's going to present with weakness. And that's medial pontine syndrome. Medial pontine syndrome is disruption of the pontine arteries here on the left. I'll even write here, I'll put in, this is the basilar artery. I don't think I labeled this. So you should know that basilar artery comes up and goes right up the middle of the pons. The pontine arteries come off the basilar. Any other questions? Okay. Medial pontine syndrome, done. On to lateral pontine syndrome.
Sweating.
What's the matter?
Nothing.
Just a case of the giggles for no reason.
A case of the giggles.
They have the giggles and they're red.
Horner syndrome. Take your eye down.
Yeah, for real. He's got the two-sided redness, so.
Yep. All right, lateral pontine syndrome. Lateral pontine syndrome is going to be a disruption of ICA. ICA. Anterior inferior cerebellar artery. And again, cross section through the pons, same as before. We can just go through and do some labeling. This is going to be your fourth ventricle. This is going to be your CST. Okay, cranial nerves, most medial, cranial nerve nucleus here in the pons. That's abducens. And that makes this cranial nerve number 6. Just lateral to abducens, we have facial nucleus. Facial nucleus wraps around abducens, and that's cranial nerve number 7. This is your facial nucleus. Okay, we're looking at medial structures. Up here we have medial longitudinal fasciculus. MLF, responsible for conjugate gaze. Also medial here we have this long elongated shaped nucleus. This is your, or not nucleus tract, medial lemniscus. Lemniscus. Moving a little bit more laterally, we have This tract responsible for crude touch, pain, and temperature sensation. That's going to be your STT. Usually hanging around with your STT, there's another small little tract, disruption of which causes Horner's. That's your sympathetic tract. Okay, responsible for receiving sensory information from the head and face is going to be the spinal nucleus of trigeminal, the kidney bean shaped spinal nucleus of trigeminal. This kite-shaped nucleus, this vestibular nucleus, and the cochlear nucleus. Thinking about that main peduncle used to send afferent information into the cerebellum is going to be your inferior cerebellar peduncle here in pink. Over here also we have the main peduncle used by the cerebellum to project efferent information out of the cerebellum, and that's going to be your superior cerebellar peduncle. And finally, this large area here, that's your middle cerebellar peduncle. We talked about this, the lateral pontine syndrome, being a disruption of ICA. And ICA, you know, comes off the basilar artery. So here's the basilar artery sitting in here in the center. The basilar and the pontine arteries supply the medial portion, and it's going to be the job of ICA, make it purple, I guess. So ICA coming off here is going to supply the lateral portion of the pons with blood. So this is going to be ICA, and the specific territory that ICA supplies with blood is going to be everything lateral to what the pontine arteries supplied. So that's going to be in this region here. Okay, so all these things are going to be affected. So when we think about ICA being affected, so that person is going to have problems with pain, temperature, and crude touch sensation. They're going to have Horner's syndrome because the sympathetic tract has been affected. They're going to have trouble with sensory perception on their face due to the spinal nucleus of trigeminal being affected. They're going to have facial droop. Okay. They're also going to have problems with the vestibular system, as well as these peduncles being affected are going to result in ataxia. Okay. So here's another little saying that you can remember for disruption of ICA. So saying is, with facial droop and ataxia, ICA is pooped. Okay, with facial droop and ataxia, ICA is pooped. Just done. Okay, so while lateral medullary syndrome, lateral medullary in the medulla, had a problem with hoarse voice and swallowing, lateral pontine syndrome is going to have a problem with facial droop. Okay, so you know you're in the pons because it's cranial nerve number 7. You know there are 4 cranial nerves in the pons, 5, 6, 7, and 8. Oh, 5, 6, 7, and 8. 4 cranial nerves in the pons. If 7 is affected, you know you're in the pons. Okay, so a lot of information just by paying attention to what cranial nerves are there and where they are. Questions? Yes? Absolutely. Patient presentation. You are going to get a problem with STT is going to be disrupted, so you're going to get a loss of crude touch, pain, and temperature. The sympathetic tract is going to be affected, so you're going to have a patient presentation of Horner's syndrome, meiosis, ptosis, and hydrosis. Spinal nucleus of trigeminal has been affected, so you're going to have an absence of sensory information coming from the face. Facial nucleus has been affected. You're going to have facial droop. Okay. Vestibular and cochlear nucleus has been affected, but specifically the vestibular person might have some dizziness, as well as it goes along with all the disruption of both the superior and the middle cerebellar peduncles. That person is going to present with ataxia, which is a general name for lack of coordination. Ataxia, not just a foreign car. Any other questions? We're almost there. See sleepy faces. It's been a tough week already. No? Pretty easy? Okay, that's lateral pontine syndrome. Moving on. We want to go to the last drawing of the semester. Medial midbrain syndrome. Again, it has its own name. It's called Weber syndrome. Medial midbrain. It's an easy one. Okay, so you know you're in the midbrain. The easiest way to tell that you're in the midbrain is because you have this nice portion of the ventricular system here. That's your cerebral aqueduct. Thank you. Your cerebral aqueduct there. That's the midbrain. You also know you're in the midbrain because you've got this nucleus, not part of the patient presentation, but I like to add it because it's a nice landmark. This is going to be your red nucleus. Everybody remembers that's in the midbrain. Your red nucleus. Okay, so this is going to be, let's label this. This is going to be dorsal. This is going to be ventral. It's going to be the right side, and that's going to be the left side. Cranial nerve in the midbrain that exits ventrally. Right here in the middle, this is going to be your oculomotor nucleus and third cranial nerve.
That's abducens?
Oculomotor. Abducens is in the pons. 3. 1, 2, 3, 4 above the pons. 3's in the midbrain. Okay, trying to keep the colors the same, I think. So this is going to be that elongated shape. It's not quite medial anymore, but here's your medial lemniscus. Okay, still very medial is this medial longitudinal fasciculus, conjugate vision, conjugate gaze. Okay, that's your MLF. Okay. Okay, sensory tracts are still there. This one's going to be more lateral as usual. This is going to be your STT. And we also have hanging around with the STT your sympathetic tract. Causes Horner syndrome. One more big one is going to be, these are most ventral. Okay. Great, big, and huge. These are your cerebral peduncles that are composed of both your corticospinal and your corticobulbar tracts. So this is your cerebral peduncles. CST and your corticobulbar tracts. Whoa. There. Okay. You're in the midbrain. So the artery coming up from the pons. Oh, sorry, guys. Just above the level of the third cranial nerve, this is going to be your basilar artery. Excuse me. Thank you. Thank you. And then coming off your basilar artery, and flipping all the way back, it's going to be your PCA, posterior cerebral artery. Okay. And Weber syndrome is going to be a disruption of basilar and or PCA. Let's just say basilar and the PCA, posterior cerebral artery. And here's your posterior artery. Since it's medial, we just have to look at medial structures that are going to be affected. Okay, this is my midline. Okay. And the area that the PCA and basilar artery supplies is going to be here. All this stuff in the middle, it's going to be affected. Cerebral aqueduct isn't affected, but you're going to have all that area be affected in Weber's syndrome. Patient's going to present with weakness of extremities. Okay, they're also going to present with motor deficits to cranial nerves where applicable, except for really the facial is going to be the one that's going to get hit because others are redundant. You're also going to have problems with the oculomotor nucleus. Okay, cranial nerve 3 deficits. And you're also going to have a disconjugate gaze due to the medial longitudinal fasciculus being affected. Okay. Since cranial nerve 3 supplies the majority of extraocular eye muscles, if cranial nerve 3 is affected, that eye is ordinarily it's called in a down and out position. Okay, so it's coming out because lateral rectus is still there and superior oblique is still functioning, but it's called so the patient presents with an eye in a down and out position. Okay, that's what you see because of all these and a blown pupil. Questions? Yay! Yay! Yes. Yeah. So you're going to have if the cerebral peduncles are affected, you're going to have weakness, extremity weakness, okay, or trunk weakness. You're also going to affect the corticobulbar tract. The main one that isn't redundant is going to be cranial nerve number 7. Remember the cranial nerve number 7 coming down. If it's an upper motor lesion, upper face division is preserved because that's bilateral. It's going to be the lower face division that's affected. Okay? Now, moving on up, the next one that you see is cranial nerve number 3, the oculomotor nucleus. Patient's going to present with an eye in what's called a down and out position, and typically with a blown pupil because the pupillary constriction isn't happening. You're also going to have medial longitudinal fasciculus be affected. That's going to result in a disconjugate gaze. And that's it. That's Weber syndrome.
What parts of the cerebral peduncles again? You said.
What parts of the what did you say?
Cerebral peduncle, just all of them.
Just this right here is just so you're going to hit a part of the cerebral peduncle. So you will see deficits in patient strength and facial expression. Got it. Okay. All right. We're done.